Good afternoon, and thank you for joining me as I share our project to improve the safety and tolerability of oral zinc to treat acute diarrhea in children. My name is Karen Kopacek. I'm a pharmacist and faculty member at the UW-Madison School of Pharmacy, and I'm proud to represent my healthcare team, which includes Kevin Wine, Jim Svensson, and Sean Duffy, associated with the School of Medicine and Public Health. The School of Medicine and Public Health and Department of Emergency Medicine has a long-standing relationship with the community of San Lucas Toliman, which is located in the rural highland area of Guatemala. San Lucas Toliman is approximately 20,000 citizens in size and is surrounded by 16 other communities that bring the total population to approximately 40,000 citizens. These communities are made up of indigenous Mayan who speak Spanish or Kopacek. The relationship has formed an interdisciplinary service learning course for medical, pharmacy, and physical therapy students. The course is coordinated through the San Lucas Mission and local clinic or hospital. Students and faculty work in satellite health clinics with community health promoters to supplement local general medical care. And a commonly treated condition seen in these mobile clinics is pediatric diarrhea. As reported by the World Health Organization and UNICEF, diarrhea remains the second leading cause of death for children worldwide, despite having available treatments. In Guatemala, it's been estimated that a little over 50% of children under the age of 5 years require treatment for diarrhea, and that approximately 7% of all pediatric deaths is due to this cause. The recommended pediatric treatments for diarrhea include oral rehydration solutions in combination with increased feedings and rehydration, and finally the addition of zinc supplementation. There is substantial evidence to demonstrate the benefit of zinc supplementation for the treatment of childhood diarrhea. But unfortunately in Guatemala, there's limited access to the various pediatric zinc formulations, and this creates a significant barrier to treatment. The average daily wage for a household in San Lucas Toliman is $3 a day, which makes the suspensions, solutions, syrups, and dispersible tablets too expensive. So to minimize cost and increase access to zinc therapy, we have been training caregivers to use zinc tablets or capsules to make an oral solution with bottled water. But we found that this leads to compounding errors and an increasing risk for either under or overdosing the child. And the resulting solution does not contain any sweetening or flavoring agent, which leads to poor palatability and non-adherence. Our team took a multi-step approach to improve the safety and tolerability of zinc supplementation. Our first step was to compound our own zinc suspension in clinic, using a modified formula published by the Michigan Pediatric Safety Collaboration. Using zinc sulfate capsules, Oral Plus, which is a suspending agent, and cherry syrup for flavoring, our suspension comes down to a cost of $2.53 per 30 ml bottle. A comparative product here in the U.S. would cost approximately $14 per 30 ml bottle. Next, we standardized the dosing protocol using 10 milligrams and 20 milligrams a day for 10 days based on a patient's age. We next provided caregiver education to minimize dosing errors. We provide a completed medication chart indicating the number of doses per day and the length of therapy, also showing the best time of day to the caregiver when to administer zinc, which is usually around a meal to minimize nausea and vomiting. Next, we demonstrate the steps by shaking the suspension bottle and drawing up the dose using an oral syringe for accuracy. Then we have the caregiver demonstrate back to us drawing up the first dose and administering it to our child in clinic. Our next steps is to update the dosing protocol based on new information published in New England Journal of Medicine. Thank you for joining us and learning more about our project.